Greetings from Dubai, and thank you very much to organizers of MENA conference for giving me the opportunity to talk about new approach to rehabilitation of stroke patients. Actually, I will try to introduce two new techniques which are gaining popularity. These are robotic technology and regenerative medicine. They are fast developing approaches to the rehabilitation in the rehabilitation field. And one of objectives will be to explain the potential benefit of these novel strategies and to define eventually directions in future development. Despite of fast progressing diagnostic and medical treatment, stroke remain as a major medical and social problem, with estimated around 17 million people worldwide which experience the stroke each year. While incidence in developed countries somehow dropping down, it's not the case with low and middle income population where it's still increasing. So overall incidence on stroke is higher than before. Common risk factors staying the same, it's diabetes, hypertension, it's cholesterol and bad habits like smoking. But focus on research recently is directly to the genetics. And one of study recently published detected 22 new genetic loci related to ischemic stroke. Rehabilitation is a very important part of comprehensive care. And actually, the main objectives of stroke rehabilitations are, first of all, to prevent complication development of further complications, then to restore the function as much as possible to promote independent life, and eventually to reduce the economic burden, which is very high actually in management of stroke treatment. Motor function is almost always affected, and that's why one of the main focus of rehabilitation and one of rehabilitation goals to improve and to restore affected motor function. There are many strategies which are so far developed, but no one is good enough to restore the function completely, and this remains as a major problem for stroke patients. One of treatment which has some kind of support in the literature and some kind of scientific evidence is constraint induced movement therapy. This is actually the strategy where the less affected side is restricted, and patient is encouraged to use the affected side for different tasks and exercises. So idea is that repetitive movements will improve the function eventually. The problem with constraint-induced movement therapy is that selection criteria are very strict, and probably more than 75% of patients with stroke doesn't fulfill this criteria. For example, if we have severe spasticity, if patient has very limited dorsal flexion and cannot open the hand, this treatment cannot be applied. According to Cochrane review, not convincingly actually reduced disability. Even we consider this as a more efficient treatment. Cochrane said that the disability is not much reduced with this therapy. Basically, the strategy in classical rehabilitation of the motor function is to ask the patient to repeat as much as possible certain movements and to perform certain tasks. Then it will be eventually, it will lead to improve the function. And really, Cochrane review showed improvements also small in arm and hand function, as well as walking distance and walking ability. But the main question is how much repetition is enough. Some literature and some basic research claim that it has to be almost 1,000 movements daily to provide some benefit. Of course, it's not a practical, and it's not possible to be realized. That's why the new technology actually is developing and finding the place in the rehabilitation field, and it is robotic technology. Robots are machines that are equipped with advanced control techniques to interact with the users. And one of the main advantages of robotic training is that it can provide highly repetitive movements, very precise design, and especially over a prolonged period of time. So that means that patients can use the robots for the whole day and can repeat as much as he wants, and there is no engagement of other medical staff, particularly physiotherapists. So this is the biggest advantage of robotic rehabilitation, that humans are much less engaged than in classical training. And there is one comparative studies which compare robotic movements with classical training, gait training or arm training. They found almost the same results, but the involvement of physiotherapists is much less with robotic rehabilitation. Now, there are registered more than 120 different devices for management only of upper extremities. That means it gained a lot of popularity, and new products are in the market. However, not all of them are still in the practice. So basically, how robots can help to stroke patients, aside to allowing more repetition without engagement of physiotherapists and other medical and paramedical professionals, robotic equipment can help in other ways as well. First, we can divide the robots in those which are restoring the function, like orthosis, which are supporting the ADL activities, so patients can perform daily activities much easier. Then some of them are for treatment purpose. They can treat the hemiparesis, improve it, and also they can help in recovery of neurological system. Overall, we can conclude that theoretically, at least, robots improve the functional status and quality of life of patients with a stroke. Regarding to application of robots, they are roughly divided in two parts: end effectors and exoskeleton. There are some differences between them. End effector robots are those that activate basically distal part of arm or leg, and they are designed to provide a better function of the hand or the ankle foot, for example. But their use is limited. If movement is less than 60 degrees, they are indicated for movements which are less of 60 degrees. And if it's more than 60, usually they are not functional and cannot be applied. And basically, they are more simple than an exoskeletal machine, and it may complicate the control of the limbs who have a more than 60 degrees movement and who have movements in different directions. Exoskeleton are different from end effectors because they are attached to several joints, they are controlling movements on more than one joint. So that's why they are more complex. They mimic skeletal structures and they are attached to each joint to support the movements. Most of the time they are used for ambulance training to improve the gait of the patients with a stroke as well as other neurological conditions. The third type of robots are those who are supporting ADLs. They are actually stimulating patients to live more independent and higher quality of life, usually designed for upper limbs power assistance, for example, for tremor suppression. They are basically light. They are lighter than other type of robots. They can be easily handled, and very important, they are not expensive. Can significantly improve the quality of life. For example, with these robots, the patient is able to drink, to eat more independently, and to perform some other activities. Unfortunately, only few of these products are available in the market right now. The next robotics are for purpose of physiotherapy or physical therapy training. These are very expensive machines, expensive equipment, and at the moment they are basically placed in rehabilitation centers or advanced institutions. They are not used for home training. They are not used for social activities. So these robots are able, like Locomat or GEO and other products, they can provide active and passive movements, sense of touch, resistance, and of course the gait training. High price is a limiting factor. They are very expensive. And also another disadvantage is usually it takes time, probably more than 5 minutes to patients be prepared to use this robotic equipment. They consist of platform, usually treadmill platform, but then expansion or supporting system, and also a device which is attached to the extremities. So what is the future of robotic rehabilitation? According to the statement of American guidelines for stroke rehabilitation for adults, they stated that robotic devices for improving mobility, that means the low extremity function, may be considered, and for improvement of upper extremity limbs function, they are reasonable to consider. Definitely, we need a lot of research in this area, which should include comparative studies, one equipment with the other, that must be conducted to get conclusion about real benefit of robotic equipment. And in the future, we can expect further development of technology, which will make robotic devices more sophisticated and more practical. And eventually, what we want to see finally, use a robot in daily life, home use and social activity use, rather than only for training purpose in rehabilitation institution. Training should be also conducted in real rather than environmental, in a virtual environment. The next new technology which gain more and more interest and popularity are stem cells. They attract attention of scientists, clinicians, as well as our patients. So what are the stem cells? These are very specific cells in our body. They are undifferentiated cells with ability and potential to self-divide and differentiate into other types of specialized cells, and eventually to restore the damaged function. To put in simple words, when we are born with the form organs, and organs are developed from the tissues and from the cells. So we have already designed cells for certain organs, like osteocytes, which will produce the bone, and also chondrocytes producing the cartilage, and myocytes for the muscles, tenocytes for tendons, etc. But we have a certain number of cells who are not designed for any particular organ. They are not differentiated. However, under certain conditions, especially, for example, after injury, they have ability to divide and to differentiate in theoretically any type of other cells, and will be able to replace or to repair any organ which is damaged. So this is the theoretical concept of stem cells, and this is there are specific features which make them very interesting and attractive for science. There are many divisions of the cells, depends what we are looking for. For example, regarding to origin of the cells can be embryonic and adult. Regarding to their potency, totipotent, multipotent, pluri, and unipotent. Totipotent are not in the practice. Pluripotent are usually embryonic cells. There are legal issues and medical issues here, because embryonic cells originally they produce the tumors like teratoma, and also we need to sacrifice the embryo, which is legally unacceptable. A big interest in the last years produced the induced pluripotent cells. They are discovered by Japanese scientist Yamanaka, who actually designed the cells with the similar features as the embryonic, but less harmful and actually acceptable for the clinical practice. These induced pluripotent cells need further investigation development, but they are very promising actually for the treatment of many conditions. Then we have very small embryonic cells. We don't know much about them. They are still not in the practice, and they are subject of further investigation. Another division depends on origin, from which tissue they are coming, in which kind of tissue they are forming, mesenchymal and hematopoietic. For us, in the rehabilitation of the stroke and other patients, mesenchymal adult stem cells are the most important, because they can generate this mesenchymal origin structures, and also neuron-like cells that have features of the neuron tissue. And another, finally, we can extract the cells from our body. We call them autologous, or we can extract from the same species, but other person, they are allogenic, and finally from different species, but we call it xenogenic. It's important to know that there is no immunological issues, immunological competencies regarding to stem cells, so there is no rejection even if we receive the cells from other species. In stroke population, we use mesenchymal, adult mesenchymal stem cells, which can be differentiated, as I said, in chondrocyte, osteoblasts, and neuron-like cells. They can be isolated from almost all tissues in mammals. Before, scientists believe that they are only placed in certain tissues like bone marrow and adipose, but now we know that almost each organ in the human bodies possess certain type and quantity of stem cells. In acute stage of stroke, mesenchymal stem cells have a significant neurotrophic effect. We will talk about it later, about their mechanism of action, but basically it includes anti-inflammation, anti-apoptosis, angiogenesis, and eventually neurogenesis. There are a lot of published papers as a preclinical studies which are done on animals, and which provide a very promising results, and prompt the scientists to try to translate into the clinical research and eventually application in clinical practice. Two articles are very significant. Actually, one, they talk about affect neural stem progenitor cells and immortalized neural stem progenitor cells, which are grafted intracerebrally around the lesion of ischemic stroke. And also they can be applied through the venous system intravenously. That's found that these cells provide a functional recovery in stroke patients. Actually, these are very promising results. And the question was how these cells migrate to the area of ischemic stroke, how they can find a place where they should be to regenerate the damaged structures. Scientists believe that it's mediated by injury-induced chemokines, like for example, some of them are stromal-derived factor 1 and monocyte hemoattractant protein. So when injuries happen, when the stroke happens, it's coming production of these substances, and these substances somehow guide the cells to the right place. Another interesting observation from one of study is that survival on transplanted cells is not always associated with functional recovery. This is very interesting because obviously we have a different therapeutic outcome in different patients, and the question why it is so. One of answer is that in some cases, the cells which reach the place or niche where the injury happened don't establish proper interaction with the surrounding cells through the signaling system. And because if they don't interact with the cells which are already there, they cannot work and they cannot provide any therapeutic improvement. Other studies use different sources of cells like bone marrow, umbilical cord, peripheral blood, and adipose tissue cells. They found that all above mentioned cells are associated with the functional recovery of ischemic stroke in experimental animal models. And again, conclusion that their migration is probably explained by and mediated by injury-induced chemokines. It was found that transplanted cells, no matter how they were delivered, disappeared very fast from the brain area. This is the finding which changed complete explanation of how the cells work. Basically, initially, somewhere 20 years and more than 20 years ago, the only explanation was that cells are engrafted in the injured place and they start regeneration process, or they start transformation into the new cells. This theory is not supported anymore. It's replaced by another more acceptable theory that cells which actually have a very short life in the body, they stay not more than 7 days, they are producing certain regenerative potential substances, and these substances actually make the work. They are regenerating the tissues. This is so-called paracrine effect or probably trophical effect, rather than neural replacement, and it plays the major role. The next study tried to approach this to the clinics, and they made combination of rehabilitation with the stem cells, and they hypothesized that combined therapy can provide a better therapeutical outcome. So this is what we call today new field, regenerative rehabilitation, which is developing very fast. To be more efficient in clinical practice, we need to answer some basic questions, which are still not answered at the moment and which are subject to very intensive research. For example, one of them, which type of cells from which origin is the most efficient? We have bone marrow, we have adipose, we have embryonic, we have induced pluripotent. Which one actually is the best for stroke rehabilitation? Another question is about the dose of the cells. How many million of cells is enough? What is the minimum number of cells that can work and can be efficient? These are the questions, again, without answer at the moment, and there is no unique attitude in the science. There is no unique consensus. There is no basically consensus about it. The next question is a route of application. They can be delivered in different ways, through the intravenous, intraarterial, or directly to the brain. Still, we don't have scientific evidence which of these methods is the most efficient. And finally, very important is proper selection of the patient. Obviously, not all stroke patients are eligible for the cells, and not all of them will respond favorably. They can be used in acute or subacute or chronic cases, and where they are the most efficient, it has to be explored in the future. So coming back to the key points, what we can expect from this treatment, from stem cell therapy. We can expect that it works in different ways. They works not only through reorganization of neural network, but they can also reduce inflammatory process, ameliorate apoptosis, and promote of angiogenesis. They can eventually support axonal regeneration and synaptic sprouting, and possible to reduce glial scars. Two mechanisms are, as I mentioned, in place right now. Cell differentiation, which is unlikely and at least cannot be explained in many cases, because the life of the cells is very short, and probably it is secretion of paracrine factor or so-called bystander effect. Recently, big attention is paid to the role of extravesicles as a vehicle. So these are substances, for example, the most explored them are exosomes. These are substances which are detached from the membrane of the cells, and they are transferring certain substances to other cells. Basically, there are vehicles for communication between cells. This communication and this signaling system between cells is one of the key factors for their efficacy. So exosomes are very much investigated recently. Even we had in United States some ready-made exosome products which are sold actually rather than extraction of the full cells from the body. Now, clinical practice, what is published so far? There are not many articles and there are not high quality studies, but at least I pick up some of them which are promising, which give some hope that in the future this might be eventually, regenerative medicine might be front runner in rehabilitation of the stroke patients. One of the studies is open label prospective. It's 10 patients. All studies suffer a small number of patients and short follow-up. So this is one of negative points of this research. So 10 patients, all of them with ischemic stroke with acute middle cerebral artery occlusion. They used the bone marrow stem cells from iliac crest. Application was intravenous, follow-up 6 months. In this study, out of 10 patients, 1 patient died, but cause was not related to the treatment. It was pulmonary emboly. In 2 patients, stroke area expanded. That means there was some kind of deterioration, but the other patients, 7 other patients, got functional improvement without adverse reactions. Conclusion is that bone marrow extracted stem cells are safe and feasible for acute ischemic stroke patients. The next study included 24 patients. It's prospective, non-control. Diagnosis are chronic ischemic and hemorrhagic stroke. Source of stem cells, again, autologous bone marrow, mononuclear cells, and way application, either intrathecal transplantation, mainly intrathecal transplantation, followed by neurorehabilitation. Follow-up is not mentioned, but it was not long-term follow-up, it was short. Results show that out of 24 patients, 12 improved in ambulation, 10 in hand function, 6 in standing balance, and 9 in walking balance. Also, it is observed that people younger than 60 years get a better result than those above 60. Ischemic stroke responded better than hemorrhagic. Stroke lasted less than 2 years, provide better result than if it's longer than 2 years. And finally, an interesting patient with right brain involvement responded better than those with the left one. Conclusion is that combination bone marrow mononuclear stem cells and neurorehabilitation is safe, feasible, minimally invasive, and viable option. Other studies, again, prospective single-arm 10 patients, ischemic and hemorrhagic stroke patients. They use olfactory cells, neural progenitor cells, umbilical cord, mesenchymal, and Schwann cells. Application was intrathecal, intracranial, thecal, and intravenous. Follow-up 6 months to 2 years, and they concluded that all patients improved speech, muscle strength, muscle tension, balance, pain, and breathing. Conclusion is that this new strategy with injection of regenerative cells, different type of regenerative cells from different sources, seems to be safe and beneficial, at least in initial stage of chronic stroke. So future perspectives, actually the results are so far inconclusive, but with some tendency toward better functional outcome. There is tendency to better functional outcome. So better understanding of stem cells and their properties and their functioning is the most important. This is the key point, how they are acting, how they are interacting with their environment, what are the obstacles for themselves to develop and to provide therapeutic effect. So this is the subject of intensive research right now. Another is proper selection of patients who might benefit of treatment. Obviously, not all of patients with the stroke are good candidates. And another is the most efficient route of application. We have many routes right now, and we don't know, particularly for stroke patients, which one is the best. Then timing, dosage, and selection of proper cells, these are another questions. Safety profile is high so far, but it needs to be confirmed in the long follow-up studies. So obviously, there is a lot of things to research. This is very exciting. There is very fast developing medical field, and what we can expect in the future to get answers at least to some of the mentioned questions, and to have more patients treated with stem cells and better therapeutic outcome. Thank you very much.